السلام عليكم. طبعا my name is Qassim Alkhazmari and I'll be presenting a few parallels for the board in terms of ECGs. The title of the lecture is simply ECG for the board for the Saudi Board of Internal Medicine, of both part 1 and part 2. These are the commonly asked ECG. But first, our objective for this talk is about approach to reading an ECG. What do we mean by myocardial ischemia and how to detect it in an ECG pattern? The form of blocks, tachyarrhythmia and bradyarrhythmia, and any other form of miscellaneous ECG that could be commonly asked. So there are more than one approach to reading an ECG. One simplified approach is the 8-step approach, where you look at the rate, the rhythm, then you check your axis, then you look at your fixed intervals, you look at your P wave, morphology and duration, then you look at your QRS complexes, your ST segment, and your T wave. Then an ECG is just part of your diagnostic tool. So an overall picture needs to be projected into a patient. So for a proper interpretation of an ECG. So the first thing is the rate. There are more than one method to estimate the rate. There are those that uses the 300 divided by the number of big squares between the RR interval. That could give you a quick estimate. Another method that we commonly use is calculating the number of QRS complexes in one single in the rhythm strip down by the ECG paper. Then we multiply it by 10 because this only gives us a reflection of almost 6 seconds. We tend to use this mainly when we have an irregular rhythm or when we have a severe bradycardia or irregularity in an AFib or complete heart block. These are the common methods that we use for rate assessment. So in these cases, what is the rate? If we use the 300 divided by the number of big squares for the first strip, it will be around 150. If we use it also for I think it is around 2.5. So if you divide 300 by 2.5, it is something around between 110 to 130. And in the second strip, it is almost two big squares. So 300 divided by 2 will be equal to 150. The last one, it is way bigger than that. It's almost 1, 2, 3, 4, 5, 6 and a half. So 300 divided by 6.5 is almost around 40 to 50. So this is most likely a bradycardic rhythm. Other than the rate, another thing we need to check is the rhythm. What do we mean by the rhythm? Is there a P wave before every QRS complex, and is there a P wave followed by a QRS complex? And the regularity of those, both the P wave and the QRSs. If you cannot clearly identify a P wave behind every preceding any QRS complexes, it could indicate either a junctional rhythm or a form of a heart block. So compare it to the next beat. Is there a P wave, or is there not? Is there a P wave present, or are we still missing that P wave? So those P wave indicate whether it is a sinus rhythm or not a sinus rhythm. It tells us that this rhythm is originating from the SA node, indicating that it is a sinus node. So if there is no P wave, then a QRS complex, this means indicate that this is non-sinus P wave. So are those sinus P waves? Some of those beats do not have any preceding P waves. So these are most likely a junctional escape rhythm. Even both those rhythms do not show a clear P wave. So the sinicity of both rhythm is less likely. You might assume that there could be a P wave on here. It may be a P wave, but this could be a T wave. Then this is a P wave. But if you compare this to this might be the only P wave. So this is most likely a junctional escape rhythm with frequent sinus rhythm. So what do we mean by the axis? The electrical signal throughout the heart have a total vector that is directed toward the normal axis, which is downward and outward. So it is toward the legs and away toward the lateral, laterally. So it is downward and lateral. Two leads we tend to use to check for axis is lead 1 and lead AVF. In lead 1, if both are positive, then this indicates a normal axis. If lead 1 is positive, so lead 1 will be positive. So lead 1 will be positive. So yeah, lead 1 is positive, so it will be somewhere around here. And lead, sorry. So yeah, if both so if lead 1 is positive and lead AVF is negative, then the axis is most likely it is a possible left axis deviation. But in this case, in the second case, you'll always check lead 2. If lead 2 is positive, so it's positive 60, then this is most likely a negative, a normal axis. If lead 2 is negative, then this is most likely a pathological left axis deviation. If lead 1, again, is negative, so it is in the opposite direction. And lead AVF is positive, so it is in the right axis deviation sector. And if both are negative, then this is most like an extreme axis deviation. The whole one of the uses of the axis is to determine if there is any fascicular block, left anterior or left posterior fascicular block, that we will talk about later on. So this is the exact same thing that applies. So lead 1 is positive, lead AVF is negative. So this is most likely possible left axis deviation. So we'll compare it to lead 2. Lead 2 is negative. So yeah, this is most likely a pathological left axis deviation, a second rhythm. And in this last one, both are face. So this is the last one is the right axis deviation, both negative and positive. So this is the right axis deviation. So those rhythm tend to present a block. So this is a sinus rhythm. There's clearly a P wave, then there is a QRS complex. But the duration between the PR interval is kind of prolonged. It is more than 0.2 milliseconds. Any prolonged PR interval indicate a form of block. In the first one, this is a first degree heart block, while in the second one, this is a complete heart block. There is no clear association between the P waves and the QRS complexes. You could see the abnormality, that positive deflection in the down slope of the ECG that indicate the P wave. And the P wave tend to go in parallel with it tend to go in its own rhythm and on its own rate, while the QRSs go in its own rate. They are not associated by any mean. So this might indicate a complete heart block. This again applies to the same thing. This is a progressively prolonged PR segment. Sorry, this is a fixed. The first ECG rhythm shows a fixed PR segment, then a dropped beat. This indicates a MOPS type 2, which can easily progress to a complete heart block. This is one of the indications for permanent pacemaker, is those with a MOPS type 2 heart block. In the second one, it progressively prolonged. Then you escape a rhythm. If it is asymptomatic, we'll observe, and if it is symptomatic, we might consider permanent pacemaker. So we looked at the P wave, then we looked at the PR segment, then we looked at the relation between the P waves and the QRSs, and we try to ensure that the duration is fixed and those intervals are all fixed. If they were prolonged, then it is something that should raise a concern in our mind. So what are blocks? We have the first degree block that have a PR interval that is fixed and more than 0.2 seconds. A MOPS type 1 that progressively prolonged, then you will have a drop beat. That gradually lengthen, then you have a drop beat. A MOPS type 2, you have a PR segment that is prolonged but fixed. Then your QRS will drop randomly. Then you have a type 3 block, which is the PR and QRS are both dissociated, where the PR is varying and the QRS is zero. So you'll have to tend to identify the P waves that tend to be embedded within the QRS complexes. You always compare the T wave of one pulse to the previous one to check if there was any embedded P wave within. So for that, the normal intervals in an ECG is that a PR interval is usually zero point 0.2 second. It's usually less than one large box. A QRS is usually 0.1 or less than three small boxes. A Q interval is 450 in men and 460 in women. طبعا it is corrected to age, which is the QT measured divided by the square root of the RR interval. The machine tend to do the corrected QT for you, so keep that in the back of your mind, the corrected QT segment. So this is a case of a lady that is 17-year-old, found by her roommate unconscious. If you look at this ECG, it shows a prolonged QT segment. So, and someone that is young and asymptomatic that present with that is unconscious, think about malignant arrhythmia. You have your long QTs, you have your Brugada syndrome, and then you have your congenital heart disease. That might explain it, your HOCM and your ARVC. They tend to present with unconsciousness or syncope, or even sudden cardiac death could be their first presentation. طبعا lung QT could be managed with a simple beta blocker unless you survive a cardiac arrest. So what are the causes of QT prolongation? We know that anything more than 460 in both genders tend to mean a QT prolongation. Your drugs, your ABCDs, your antiarrhythmic, your anti-anginal, your antibiotic, your antipsychotic, your antidepressant, your diuretic, and your antiemetic. These are medications that are commonly prescribed that are known to cause QT prolongation. So a baseline ECG before prescribing those medications and a follow-up ECG to determine how sensitive they are. Any form of electrolyte imbalance tend to cause acute prolongation, hypothermia, or genetically inherited, or any form of increased intracranial pressure. Especially those with massive stroke that result in increased intracranial pressure might have a form of QT prolongation. طيب. Now we talked about all different intervals and the axis and rate. Now we'll talk about the morphology of different parts of the ECG. The P wave is your sneak peek into your atrial assessment. So it is usually upright in the inferior lead because it is away from it. And a P wave can help with atrial enlargement. A right atrial enlargement will have a peaked P wave in lead 2. So the most important two leads in the assessment of atrial enlargement is lead 2 and lead V1. Lead 2 will have a peaked P wave of more than 2 as you can see in the diagram shown in the right. A right atrial enlargement, it will be peaked. A left atrial enlargement, it will be prolonged. This is one clue. And if it is both peaked and prolonged, considered by atrial enlargement. This is in regard to lead V1. Lead 2, I mean. For lead V1, it will be different. It will be also peaked. Peaked in the case of right atrial enlargement, and with the terminal negative, and in case of left atrial enlargement, the terminal negative portion will be deeper. And if both are present, a peaked first segment and a deep second segment in lead V1, this indicates a biatrial enlargement. If a P wave is very prominent and it is you could clearly identify certain margin, consider atrial enlargement, then divide. The first segment indicate your right atrium. The second half is your left atrium. And by that, it kind of makes sense if you think about it that way. And in this case, you will see that there is a peaked P wave in lead 2, and there is a negative portion of lead V1 that is prominent and more than one small square. With this picture, you would assume a biatrial enlargement. Always compare both leads. Lead 2, it could give you a picture into the right atrium because lead 2 is kind of looking at the heart from its inferior aspect, and the lead V1 is kind of placed in front of the chest. So always combine both lead 2 and V2 to decide if there's any biatrial or a single atrial enlargement. So now we did the P wave. Now we do the QRS complexes. There are four things to look at the QRS complexes: your amplitude, your duration, and if there is any form of Q wave and the R wave progression. So we'll start with the amplitude of the QRS complex. This does help you with deciding if the patient does have LVH. A commonly used criteria is adding the large S wave of V1 and V2 to the large R wave of the lateral lead, V5 and V6. If it is more than 35 millimeters, then this is most likely LVH. This does have a specificity of 96.7%. Looking at this ECG, lead V1 and V2, if you combine them both, it is more than six big squares. So this is most likely an LVH. And the duration, so now we looked at the size, how deep they are, or the amplitude. Now we look at the duration. If it is a prolonged, think about conduction abnormality. You have your left and you have your right bundle. One way to look at them is that in lead V1 is always pointed, will show you the direction of the bundle branch. If it is going to the left of the isoelectrical line, this is most likely a left bundle. If it is going right, then this is most likely a right bundle. A quick way to estimate it. But you will have always a dominant S wave in V1 and a broad monophasic in the lateral lead. Because of the way the conduction happens, is that the right system will be, the right side of the heart will be activated first, followed by a slow activation of the left side that is detected by the lateral lead, activated by myocyte to myocyte, not through the normal conductive system. In regard to right bundle branch, it will have an RSR pattern, which is called the rabbit ear pattern, or the M-shaped. And with a slurred S wave in the lateral leads, it is, again, the exact same thing. In this case, if you see there is a positive deflection in lead V1, indicating that the right system was activated first. Then it went away from the electrode, and then slowly depolarize the right system from the left system to the right system. When we talked about left axis deviation and right axis deviation, we meant to say that we need, if you see a patient with left axis deviation or right axis deviation, always consider the possibility of left anterior fascicular block and left posterior fascicular block. This is not commonly asked, but it is kind of good to know. In left anterior fascicular block, you will have left axis deviation, which is by looking at lead 1 and lead AVF, they will, and then you will have a look at the QR complex in lead 1 and AVL. It will be negative. They will be, in lead 1 and AVL, they will be pointing toward each other. While there's an RS complex in lead 2, 3, and AVF, an R and S complex. Yeah. Then for a left posterior fascicular block, you will have right axis deviation, and then you will have a QR complex. Then you'll have a QRS complex in lead 2, 3, and AVF. Just kind of to make it, to simplify it, what we mean by a QRS complex is a positive lead. So lead 2, 3, and AVF will be positive, while lead 1 and AVL will be negative. And this is in the case of left posterior fascicular block in the setting of right axis deviation. If it is a left axis deviation, then you will have a positive 1 and AVL with negative inferior lead. So they are all negative with an RS complex in lead 2, 3, and AVF. So this is in regard to fascicular block. The R wave progression, they usually will have a normal transition. This is the normal R wave progression. It tends to translate between V3 and V4. If there is a delay in the progression, if there is a early progression, consider right bundle branch morphology, RVH, or posterior MI. If there is a delay in progression, consider any form of pulmonary disorder that might explain it. COPD is a cause of delayed R wave progression. So between V3 and V4, your R should equal your S. If it is not, then there is something wrong. If it happens earlier at lead 2, your R equal to your S, think about right bundle, RVH, and posterior MI. So yeah, as we said, the late progression. So the last thing, now we did the QRS complex. We looked at it from an amplitude, from a duration, from a progression. Then we look at the ST segment. So we know the coronary artery anatomy. You have two systems, the right and the left system. They kind of subdivide and supply all different aspects of the heart. So a STEMI, or obstructive myocardial infarction, is a more than 2 millimeter ST segment elevation in the precordial lead, or 1.5 in the women, or more than 1 millimeter in other leads, which is the lymph lead. A new left bundle branch or a posterior MI are both considered obstructive myocardial infarction, and they're usually looked upon in lead V2 and V1 V2 and V3 with the ST segment depression, and a new left bundle branch in the setting of hemodynamic instability is considered a STEMI equivalent. Since the most common cause of left bundle branch is chronic hypertension and cardiomyopathy, and a patient presents with the chest pain that is hemodynamically stable carries only 0.3% increased risk of ACS compared to the general population. So the new guidelines said if they are stable and hemodynamically stable, just observe them and make sure that they're not something else. So these are ECG that show the C-segment elevation in the inferior lead with, it shows the segment elevation in the inferior lead and with reciprocal changes on the anterior lead, and especially lead V3 and V2. Also, the second ECG below shows a lateral ST segment elevation and with reciprocal changes. This kind of shows the exact same thing but more prominent. So ST segment depression is either upsloping or downsloping or horizontal. A horizontal or downsloping ST segment does indicate myocardial ischemia, not infarction. ST segment depression of more than 1 millimeter is something that carries a worse prognosis. A diffuse ST segment depression is something that carries a high probability for a high risk for mortality in the next 30 days. But an upsloping ST segment depression is non-specific for any form of myocardial ischemia. It could be a normal variant or a sign of a strain pattern. Willen or a biphasic T wave is something that there are two forms of Willen. There is a type 1 and a type 2, where type 2 is a deep inverted T wave. This indicates an aborted ischemia. A biphasic T wave, which is called Willen type 1, shows a positive T wave with a negative T wave, and a T wave that is divided in two segments, a positive and a negative segment. So what do we mean by T-wave inversion? At least 1 millimeter deep, present in two or more than two continuous leads that have a dominant R wave. So an RS ratio is more than 1. It is dynamic, something not present in all the ECGs. And Wellen syndrome is something that we worry about for T-wave inversion. This is why we consider T-wave inversion something very high risk, because it does indicate an aborted STEMI or a high-risk patient. What we talked about earlier was something we commonly know and we commonly do. So we'll talk about a few things now. What do we mean by tachycardia? When we talk about tachycardia, we either mean narrow complex or wide complex, regular or irregular. A regular narrow complex is sinus tachycardia, atrial tachycardia, a flutter, and SVT and AVNRT. Irregular is your AFib, your flutter, your flutter with the variable block, and your MAT, which is your multifocal atrial tachycardia. Your regular wide complex is your VTAC, your V-flutter, your tachycardia with aberrancy, and your hyperkalemia. Irregular wide complex tachycardia is your TORSA and your VFib. So any patient that presents with a heart rate above 100, we need to sort them out. Do they have an RQRS, which is less than 3 small squares, less than 0.12, or a wide QRS? If so, are they regular or irregular? Is the distance between every RR is fixed? If it is, then we know our differential diagnosis, and this could help us in the management. So this is a patient that does have tachycardia, a heart rate of above 100. It does appear to be regular, and it does appear to be regular and with the narrow QRSs, which is less than 2 small squares. So this is a narrow regular QRS complexes. Our differential diagnoses include, as we said, atrial tachycardia, atrial flutter, SVT, and AVNRT. In this case, the most likely impression is an atrial flutter. So these are different rhythm. These are patients that have the one above does have PVCs. So this is a patient with the junctional escape rhythm and premature ventricular contraction. There are no clear P wave preceding every QRS complexes. And then the diagram below shows a P wave of different morphology preceding every QRS complexes. So this might indicate a multifocal atrial tachycardia. Okay, so, and these are wide complex regular tachycardia. As we said, these are your VTAC VTAC, your AFib with aberrancy, and this irregular polymorphic apparent rhythm does indicate a torsidopointis or ventricular fibrillation. So, for bradycardia, we either have narrow versus wide complexes. We have regular or irregular complexes. Any regular narrow bradycardia, either sinus, junctional, or a complete AV block with a junctional escape, atrial flutter with high degree a high degree block. Irregular narrow complex bradycardia is your sinus or AFib with slow ventricular response, A flutter with variable block, type 1 and type 2 block. An irregular wide complex bradycardia is adventricular rhythm, complete AV block with ventricular escape, regular bradycardia with apparency or bundle branch block. Irregular wide complex is type 1 and type 2 degree block, and irregular bradycardia with bundle branch block. So it's kind of to simplify it, bradycardia, the same rule applies to it. Either it is narrow or wide, irregular or regular. If it is regular, it's kind of most likely a junctional escape rhythm, or sinus bradycardia, or and these are the common. If it is irregular but narrow, think about AFib, your common AFib, or your type, or your heart block, type 1 and type 2, MOPS type 1 and type 2, because the PR segment, as we said, it will causes a form of irregularity. So if we have a regular wide complex, this is your ventricular escape rhythm, or the patient with apparency and severe bradycardia. So it could be sinus bradycardia in a patient with an underlying bundle branch block. So it will appear as bradycardia with a wide complex. But irregular wide complex, again, same rule apply. It is an irregular bradycardia, underlying fibrillation with an underlying branch block or any form of MOPS type 1 or type 2. One of the important things that we keep in mind is hyperkalemia, especially in the boards. Hyperkalemia tends to present with a peaked T wave, especially if the potassium is more than 5.5. And this carries the myocardium become hypersensitive to the point that it could result in a sinus wave. The more the hyperkalemia progresses, there is paralysis of the atria with the widening and the flattening of the P wave and the PR segments. Everything got pulled out. Think about it like that. Everything, initially you'll see a peak T wave, then all the strip will be pulled out. So the PR segment will prolong, the P wave will widen and flatten until it is a sinus wave. Like everything pulled until it is a flat line, until the patient dies. A prolonged QRS interval with any bizarre complication, sinus brady. طبعا a sine wave is we call it a pre-terminal rhythm. It is the rhythm. Hyperkalemia is a joker of rhythm. It could present as from a simple T wave to a PR segment elevation to a wide QRS complex to a prolonged QT to escape rhythm to a sine wave as a pre-terminal rhythm before arrest. So this kind of applies to it. So and this it is a slow bradycardic, and this it is also wide QRS complexes with no clear P wave, and this is a sine wave. A potassium of more than 9 usually causes a cardiac arrest with ventricular fibrillation or pulseless electric activity with bizarre wide complex rhythm. Always check your potassium and give calcium gluconate until the rhythm is corrected. For that, electrolytes tend to cause their own changes in the ECG. As we said before in the QT segment, most of the hypocalcemia and hypomagnesemia and they tend to cause a QT prolongation. And the opposite tend to happen in a patient with hypercalcemia. They will have a shortened QT interval, and hypermagnesemia they will have in hypercalcemia they will have a shortened QT interval with a wide T wave. This tend to apply in any patient. We tend to see this rhythm in a patient with underlying malignancy or malnutrition. as malignancy usually causes severe calcium, especially in tumor lysis syndrome. We'll see high calcium, so we tend to see the narrow QT interval, or patient with in preeclampsia or eclampsia, when magnesium is given at high doses, they tend to see a prolonged PR interval with widened QRS complex with hypermagnesemia. So what are other common ECGs? So this is the same patient. This is a 38-year-old that came with palpitation, as we said. This is a tachycardia that is regular and narrow. So our differential diagnosis, as I said, is SVT, AVNRT, or atrial fibrillation with block or atrial flutter. The morphology of the P wave show a sawtooth appearance, so this is most like an atrial flutter. Second ECG is a 51-year-old female that came with shortness of breath. So this patient does have a sinus rhythm. There is a P wave before a VQRS complex. You could see it clearly in lead 2. He does have wild QRS complexes. It is an RSR pattern. So this patient does have a right bundle morphology. In the so this patient does have right bundle branch morphology, and in the setting of a sinus tachycardia, actually not sinus tachycardia, with an underlying rhythm of a sinus rhythm. So what could explain the shortness of breath? You could either have again, we forgot to say this, with right axis deviation, with right bundle branch block morphology, and with fascicular block. So he does have bifascicular block with sinus rhythm with bifascicular block, right bundle branch and a fascicular block. So yeah. So this is a patient with COPD that presented to the ER. So as soon as you see a patient with a pulmonological respiratory disorder that present to the ER with an ECG given, always check the morphology of the P wave. If you could identify more than 3 morphology, then this is most likely multifocal atrial tachycardia. This ECG shows in the rhythm strip down there that there are more than 1 morphology for the P wave. So this is most likely a multifocal atrial tachycardia. To manage it, you treat the underlying cause with nebulizer and steroid to treat the COPD exacerbation. There's not any. This is all the treatment for multifocal tachycardia. This is a patient that we commonly see. It's a patient in hypothyroidism that was on oral contraceptive pill that discontinued that presented palpitation. This ECG shows a narrow, complex, irregular rhythm with no clear P wave. What you could see in V1, it could be a sawtooth appearance, but the irregularity of the rhythm is not in favor of atrial flutter. So this is most likely atrial fibrillation with variable conduction, as you could see that at one point there are 3 P waves, then conducted, then there are 2, then conducted, then there's 1. So this is atrial fibrillation with a variable degree of conduction. Second, most likely to high doses of high levothyroxine as a treatment option. So yeah, this kind of makes it kind of short. Thank you for watching, and I hope you learned anything out of this.